Hi doctors, in this video we will be discussing about the partogram. So partogram is also an important part of life in our day-to-day practice. So what is partogram? So what is partogram? It is a composite graphical record. It is a composite graphical record of key data during labor. Entered against time on a single sheet of paper. On a single sheet of paper is important. On a single sheet of paper. So this is the composite graphical record of the key data during labor on a single sheet of paper. So we'll be learning some points regarding the history. The first partogram was first by the Friedman. In 1954, the first partograph was first introduced by Friedman. So this is the evaluation of the progress of the labor. So in the simplest form, it shows the dilatation and the dilatation of the cervix and the descent of the head. So this is the latent phase. Okay, this is the latent phase. Here you will be having the cervical dilatation, and here comes the active phase. Here comes the active phase. So this is about the dilatation and the station. So this shows the station. This is a Friedman's curve. This is the initial partograph. The first partograph which is identified is the Friedman's curve. Then it is further modified by Philpott and Castle in 1972. What they did, they added alert line and action line. So this was developed by WHO. Then this was modified, extensive modifications were done, and this was developed, extensively tested by WHO in 1994. And again, WHO partogram was modified in 2000 and 2006, and latestly also it is modified. So this is the latest version of the partograph we are using. So what is the latest modification done? The latest modification done was latent phase has been removed from the partograph. Latent phase has been removed from the partogram. Okay. Then what are the components of the partogram? So coming to the components of the partogram, actually all the theoretical data, it is good in Mudaliar. So no need to go around, just read Mudaliar, that's enough for partogram. So let's see in detail about the partogram. So what are the components? The first is the patient identification. Okay, patient identification. So this asks about the name and the obstetric formula of the lady and the hospital number. Okay, and then asks about the date of admission, time of admission, and if ruptured membranes, till how long the ruptured membranes is there. So this is about the patient identification. Then comes the fetal heart rate. So this fetal heart rate, you can see 100, 110, 120, 130. So this fetal heart rate, it should be recorded every 30 minutes. Okay, fetal heart rate should be recorded every 30 minutes. So if the fetal heart rate is 140, you will mark it as 140. If it is 150, you will mark it 150. Again 140, 150, 160. So this is the marking of the fetal heart rate. Okay, then you can see the amniotic fluid. Okay, amniotic fluid. So you can write for amniotic fluid as, so you have to mention the color of the liquor. If you have intact membranes, if the membranes are not ruptured, you can write I. So here intact membrane, here intact membrane, here intact membranes. And if the membranes are ruptured and if there is a clear liquor, you can write C. So here membranes ruptured, then you will write clear liquor. Then if the, after that, if there is a meconium stained liquor, or whenever there is a rupture of membrane, if it is a meconium stained liquor, you can write M, that is meconium stained. Then if there is a B, that is blood stained liquor. Blood stained liquor can be seen in cases of the abruption. So if B is present, then it is a blood stained liquor. So intact, clear, meconium and the blood stained liquor you can write. Then now you can see molding also. Okay, so this is about amniotic fluid. Now molding. So in molding you have to write the stages of molding. So what are the stages of molding? Stages or grades. The first grade is sutures are opposed, and the second grade is sutures overlapped but reducible. Sutures overlapped but reducible. And the third is sutures overlapped but not reducible. Okay, just have a look of the stages of molding. Okay, now you got an idea about stages of molding. Sutures above, overlapped but reducible, overlapped but not reducible. That you will be writing here. Grade 1, 2, 3, like that you will be writing. Okay. Then coming to the, this is about the cervical dilatation. So this is all about the cervical dilatation. So how you will write? In the cervical dilatation, see, it starts from 4 centimeters. Okay, it starts from 4 centimeters. This is the alert line and this is the action line. Okay, so from 4 centimeters, so you have to plot X for cervical dilatation. So when the patient comes at 3:30 p.m., then if it is 5 centimeters, then you'll mark it like this. If it is 6, you'll mark it like this. So whenever the situation is to the left of the alert line, So in the cervical dilatation, you will be writing about the how much the cervix has dilated at what time you will be writing. Then in this area only you have the descent of the head. So descent of the head you will be writing as if -3, -2, -1 like that. Then you will be marking it as a 0. So plotting it as a 0. Then coming to the uterine contractions. In the uterine contractions, the squares in the vertical column are shaded according to the duration. So if there is only occasional tightening, 1 or 2 contractions, occasional tightening, you will mark it like this. Okay. So this is only occasional tightening. So if the contractions increase, then you will be marking it like this. If there is an increase, very much increase in the contractions, then you will darken this. Okay, then you will darken this. So this is the method of marking the contractions. Then what you have? Oxytocin. So for oxytocin, you will be writing 1.RL with 5 units of oxytocin. If you have added oxytocin, you will be writing this. And drugs and other IV fluids given. If IV fluids are given, you will be writing this. Or if you have given any drugs like injection, hydrocot for any asthmatic patients, or if you have given injection drotin or epidocin, you will be writing here. Then coming to the pulse and blood pressure recording. So for pulse, you will be writing maternal pulse. This is maternal pulse. The first is the fetal heart. This is maternal pulse. So for the maternal pulse, you will be writing 80, 90 or 70. Like that you will be putting dots. For BP, you will be having this line, that is 120 by 80, 110 by 70, 120 by 80, 130 by 90. Like that you will be marking the blood pressure. Coming to the temperature, you will be recording the temperature every 4 hourly, and blood pressure also every 4 hourly you will be monitoring. Pulse every 30 minutes you will be monitoring. The frequency of monitoring should be remembered. BP you will be monitoring 4 hourly, pulse you will be monitoring for every 30 minutes. Okay, and then temperature also you will be monitoring. Then you will be monitoring the output of the urine. The volume, protein content, and the output of the urine is to be monitored. So this is about the components of the partogram. Okay, you have a good idea about this partogram now. So you practice in your wards just to write the partogram, then you will understand better. So these are the components of the partogram. Coming to the advantages of the partogram. Coming to the advantages of the partogram. So a single sheet of paper. So a single sheet of paper will provide all the information regarding the maternal and the fetal information at a glance, so that you need not turn many papers to know whether when it is kept, when the induction is kept, where is the cervical dilatation, nothing. Only a single sheet of paper is essential. So it can predict the normal deviation. It can predict the deviation from the normal progress of labor. So when you are having a normal progress, it can also predict the deviation. So see this. This is the alert line and this is the action line. If the cervical dilatation, we will be writing abnormal thing here. If the cervical dilatation is 5 centimeters at 5:30, and then 5 centimeters at 6:30, 5 centimeters at 7:30, and 5 centimeters at 8:30, then the cervical dilatation has not increased till 3 hours. This crosses the action line. Whenever it crosses the action line, you have to do some sort of intervention. You have to do some sort of intervention. Either you have to go for an instrumental delivery, but this is 5 centimeters, so you cannot go for instrumental delivery. You have to have an immediate delivery of the baby, as there is a arrest of the dilatation. So whenever it goes beyond the action line, then you have to have some action. Okay. So by this, you can predict the deviation from the normal progress of the labor. Okay. Then the third is that it can facilitate the handover procedure easily. So that while completing your duty, you can just hand over the partogram so that they can understand the idea about the partograph or the mechanism of labor for that patient. And you can have the early recognition of the maternal fetal problems. Early recognition of maternal and fetal problems. Then what are the disadvantages of the partogram? It assumes all women progress at a similar state. But in multi there will be difference, but in nulli there will be difference. That difference is not seen in partogram, so that is a difference. And then clinical findings may be of subjective evaluation, may have a subjective variation. So one doctor will say 4 centimeters, one doctor will say 2 centimeters, like that. There will be some subjective variation. And some of the setups will have only midwifery, so they do not have any knowledge of partogram. There's a lack of knowledge. And non-availability of printed partographs, it is not random nowadays, so this might not be a disadvantage nowadays. So this is about the advantages and disadvantages of the partogram. Okay, hope you understood the components of the partograph. Thank you for your listening.